Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to re-establish some degree of normalcy, we decided to resume the release of our episodes on the Neurocritical Care Society podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. What's up, podcast listeners? Fawaz Mufti here from Westchester Medical Center, New York Medical College, and welcome to another episode of the Neurocritical Care Society podcast. So as a discipline of medicine, critical care was founded on attempts to help some of the sickest and the most helpless patients. But we didn't get here today by accident. It's been a labor-intensive process, an uphill battle that was only possible with constant innovation and early adoption of new technologies for the simple reason that necessity is the mother of invention. Critical care is personalized, the patient is the key element, and opportunities for innovation in critical care are numerous. Today, Chris Zammit will be discussing with Dr. Wendy Ziai and Dr. Tandri one such innovation that was described in the recent publication, Feasibility and Safety of Transnasal High-Flow Air to Reduce Core Body Temperature in Febrile Neurocritical Care Patients, a pilot study that was published in the Neurocritical Care Journal in March 2019. I hope you enjoyed this episode.
Hi, everyone. This is Chris Zammit. I'm with Good Samaritan Hospital in Cincinnati, Ohio, where I serve as a medical director of stroke and the neuro ICU. We have with us today Dr. Ziai and Dr. Tandri, who are going to tell us about their paper recently published in Neurocritical Care titled The Feasibility and Safety of Transnasal High-Flow Air to Reduce Core Body Temperature in Febrile Neurocritical Care Patients, a pilot study. Thank you so much for being with us today. If you don't mind telling us a bit more about yourselves and what made you interested in this topic.
Sure. So I'll start. I'm a neurointensivist at Johns Hopkins Hospital in Baltimore, Maryland, and I got involved in this project with Dr. Tandri, and he'll tell you a little bit more about himself. But basically, based on a common problem that we all face in the neurocritical care patient population of fever that is often resistant to antipyretic agents, especially neurogenic fevers, and that we don't have that many options for good fever control. We do have, of course, the usual things, ice packs and cooling blankets, surface cooling, and ultimately more invasive devices, esophageal probes and intravascular probes. But, these all have some drawbacks. And so when I had this opportunity to work with Dr. Tandri to look at a minimally invasive device with a transnasal cooling apparatus, this was a very interesting study. And, I'll just ask Dr. Tandri to explain a little bit more about his involvement with this.
Hi, this is Hari Tandri, one of the cardiac electrophysiologists at Johns Hopkins. My field of interest has been sudden cardiac arrest and improving outcomes of patients after a sudden cardiac arrest. And one of the things that early on in my fellowship I started working on was to be able to induce hypothermia in the field. At that time, there was no good way to cool patients outside in a hospital setting, and we came across this transnasal evaporative cooling model, which can be easily implemented in an ambulance or by a bystander. This promptly reduced the temperature of the preclinical animal model, and we thought that the first iteration would be to use it to bring it to clinical value. We then approached the folks in neurocritical care, and Dr. Ziai and I collaborated to show the clinical benefit of this methodology to reduce core temperature in febrile patients, and that's how we got involved with the neurocritical care part of it as yet another application of the same transnasal physiology, and we had some exciting results, and that became the part of this publication.
Wonderful. Really appreciate that background. Before we get into exactly how you study this, can you describe a bit about how this method compares with other transnasal or is similar to other transnasal cooling approaches or methodologies?
Sure, I can take that answer. I can take that question. There are a couple of different ways in which transnasal cooling has been applied in the past. One was actually circulating cold water through balloons placed in the nostrils. This was primarily a conductive cooling, and the surface area of the balloon was important for transfer of heat or transfer of the temperature across the nasal turbinates. Obviously, this was an invasive way to do the transnasal cooling. The another method that was in vogue to cause transnasal cooling was spraying perfluorocarbons inside the nostrils through introducers placed inside the nasal turbinates. This caused a very rapid evaporative cooling, but the concerns over use of perfluorocarbon spray itself made it difficult to translate that into clinical practice, especially in the USA. And one of the big concerns with perfluorocarbon was the intense local cooling, causing some degree of damage to the nasal architecture itself. The dry air transnasal cooling, I believe, is much better way of cooling because the latent heat of vaporization of water is much, much higher than perfluorocarbon. You need to evaporate 2 liters of perfluorocarbon to get the same amount of heat extracted as much as evaporating 100 ml of water. So the latent heat of vaporization of water is probably the highest in any liquids available. So if you can evaporate water, which is found in the nasal turbinates naturally as nasal mucosal fluid, that would cause a much rapid cooling compared to spraying perfluorocarbon and evaporating that. So we came across this physiology where if you pass high flow of dry ambient air, it would evaporate the nasal mucosal water by a unidirectional flow, where the flow goes through the nose and comes out through the mouth. And the process of humidification of that air draws the energy out of the system. And also the fact that this process happens right underneath the surface of the brain causes some degree of preferential brain cooling, which is probably very advantageous in situations of neurogenic fever or even in the setting of a cardiac arrest. So that's why we believe that this method of cooling is easily translatable and probably better than the current existing methods of cooling.
That was a great explanation. Really appreciate that background. Have there been any other evaporative methodologies, as I say, cutaneous evaporative approaches that have been evaluated prior to this transnasal approach?
I think that's a great question. Cold sponging and evaporating water off the skin surface has probably been routinely used for a while in intensive care settings, but it does induce a brisk shivering response because of skin cooling, and that sometimes is counterproductive, and it does cause a big metabolic demand on the system as well. So it's been largely abandoned to do the cold sponging methodology, and even the cutaneous cooling methods that are used in ICU, such as surface cooling pads, also evoke a shivering response. And what is interesting about the transnasal cooling is that it does not seem to bring on the shivering response because I believe that probably shivering is something connected to cutaneous receptors causing the shivering flex, which is probably absent in the transnasal cooling methodology.
Wonderful. Could I ask you to describe a bit more exactly what equipment and what this looks like at the bedside when you're doing the transnasal evaporative cooling for the listeners?
I can talk a little bit about our pilot study. Now, this was a study that used a device which has now been superseded by a little bit more sophisticated device, but we basically used a nasal CPAP mask, and we ran medical-grade air through that mask, and so it was humidified air, which is, of course, one concern that can mitigate the effect of the transnasal cooling. You do need to use the driest air possible, so that's something that's been improved upon in the sort of the latest revision of the technology. But we just ran medical grade air through this nasal CPAP mask, and we did use a continuous positive airway pressure of up to 20 centimeters water for a 2-hour period in the pilot phase. And we also measured, of course, the core esophageal and the tympanic temperatures continuously during the procedure. The mean transnasal airflow rate was about 60 liters per minute, so it's quite high, actually. And we found that this was, in fact, very well tolerated. We didn't have any issues with injury to the nasal mucosa. In fact, we had ENT surgeons look at the nose and the nasal passages before we started, and then after, 24 hours after this 2-hour pilot study. And again, we didn't see any injury or have any bleeding or have any aspiration events. And so it looked like it was a very well-tolerated device, even though it was fairly simplistic in its initial design. Hari, do you want to talk a little bit about what we're using now in the Cooltech study?
Sure. I think it's a very good summary of where we started. There were, again, the process that controls the evaporation is really fundamentally the humidity of the inflowing air. The drier the air, the better the cooling. Again, the airflow rate is a very important component, and we are currently using 60 liters per minute of airflow through the nostrils. Based on our pilot study data, we built a device which now can generate up to 60 liters per minute of completely dry air. The air is passed through a desiccant cartridge to remove all the humidity, and this is pumped through the nostrils. Clearly, using the cutoffs of the CPAP device, it still uses a pressure cutoff of 20 centimeters of water just to maintain the safety limits, very similar to a CPAP machine. When the mouth is kept open, the air enters the nostrils and exits out through the mouth. The additional feature of the device that we have currently is that it spreads this water intermittently directly into the turbinates through a pipe that runs parallel to the air supply flow, so that it keeps the mucosa moist at all times. So it serves two purposes. One, it prevents desiccation during prolonged usage of this device. And second, it also provides the water that can be evaporated, almost like a swamp cooler. You provide the water and you evaporate the water using dry air, causing cooling of the nasal turbinates, which is convectively carried to the rest of the body, so the whole body cools for a period of time. So one additional feature of the new device is that it has a closed-loop control system. So the esophageal temperature probe plugs into the device, and the device regulates the body temperature based on airflow. So as soon as the body temperature hits to the target temperature, the airflow turns off and gradually comes back on when the temperature starts to rise again. So it's able to do a closed-loop control system while providing active cooling when needed.
Wonderful. So, and with your pilot study specifically, it looks like we had 7 patients that you included. All these patients were endotracheally intubated, correct?
Well, actually, one was not, and okay. That was interesting. Initially, we didn't design the study to include only intubated patients, and because the initial device did not have this nasal spritzing of saline, we were less concerned. Since then, with the nasal spritzing, we have excluded patients who were not intubated. I will say the non-intubated patient did tolerate the procedure well, but of course we would, need to study a lot more patients to say that this could be used in non-intubated patients due to the possible risk for aspiration, of course.
Can you speak to some of the patient populations who could not benefit from this methodology of cooling? Some of our traumatic brain injury patients, those who may have sinus fractures, skull base fractures, those type of patients.
Right.
Or any others that you would exclude from this methodology?
Yeah, so currently with the device that we are studying, which is now a 24-hour cooling period, we are excluding, of course, patients who have any injury to the frontal sinuses, to the facial area. We are including only intubated patients. And therefore, you're excluding at this point patients who, you may be interested in cooling, ischemic stroke patients, perhaps, some milder forms of brain injury. But the vast majority, the patients that we are studying right now are patients with brain hemorrhage. So we're looking for intracerebral hemorrhage and subarachnoid hemorrhage patients. And because these patients, do tend to have a high tendency towards neurogenic fever and often are resistant to antipyretic agents. So this is where the current study is focused. I think we'll learn about whether there are any risks to the use of the nasal spritzing device but right now the airway is completely sealed off from the endotracheal tube, and so we're not expecting that to be an issue.
Any other safety endpoints that you're looking at in the newest iteration with the nasal spritzing device?
Yeah, and drying of the nasal mucosa was the issue with the first device, which used dry air, although, of course, the humidity was from the ambient air. these are the main issues. We had, of course, looked carefully at vital signs and didn't notice any particular perturbations of blood pressure, heart rate, or even intracranial pressure. So I don't think those are of too much concern, but obviously we're monitoring all of those. Hari, did you want to add anything?
Sure. The device is designed so that it is actually a CPAP device. It has the same pressure limits as the CPAP device, and it blows air the same way a CPAP would do at that pressure limit. The only difference is that we are creating a short circuit with the mouth open. So basically, if somebody is sleeping with a CPAP device and has their mouth open, they pretty much feel the same physiology. We have partially mitigated the effect of a dry air by constantly keeping the mucosa moist, and at least from the data we have thus far, it seems that there is no effect on the mucosal drying. The mucosa appears to be well and healthy even after 24 hours of cooling. So I don't really anticipate any issues that might arise from the way that we're using it now in intubated patients where the respiratory circuit is completely isolated. We will have to study the use in patients who are unintubated down the road, and we'll probably have to make some modifications based on what we see during those studies.
Any thoughts on a risk of sinusitis with this approach, using a bacterial sinusitis?
We would hope that the risk would not be higher than the risk from nasal CPAP, without the use of this device. We had not seen any indication toward that. We have studied about a dozen patients already with the 24-hour cooling period, and there have not been any noticed adverse events in terms of sinusitis or other bacterial infections. What's your experience, Hari?
Well, actually, the mucosa appears healthy after the cooling period than the initial examination because of adequate hydration. So I've not seen any increased risk of mucosal damage or anything like that with the current iteration of the device using adequate amount of saline to moisturize the mucosa.
And I presume that patients' enteral access is being provided orally as opposed to nasally when you're using this device.
Exactly.
That's correct, yes.
Wondering your comments on the choice of monitoring the temperature via esophageal or tympanic as opposed to another location, intravascular, rectal, or bladder temperature.
We've had many discussions about this point, and because the FDA does require us to measure tympanic temperature, which interestingly is probably our least preferred method of measuring temperature.
Right.
We do use esophageal temperature probes for this study, and then there is a device that we've started to use called the spot-on device, which is a patch that goes on the forehead. We've tried to restrict our temperature readings to esophageal, tympanic, and the spot-on device. And, of course, we are not measuring brain temperature. This is not an invasive study in that way.
There were any theoretical concerns about, particularly if there's spritzing of the water, you're getting a falsely reassuring temperature reduction with an esophageal monitoring approach, and how that might compare to a bladder or a rectal temperature.
So we've had a couple of subjects with bladder temperature who had a bladder temperature at the beginning of the study and it wasn't changed or whatever. We kept that temperature and we basically have had the same type of change. One of the interesting things is that the pattern of cooling is almost, very gradual, and it really follows the tympanic temperature curve as well. And the spritzing of water is of the order of microliters. It's really not. Each spritz is a fraction of a milliliter. So I don't envision this spritz really influencing the temperature, because by the time it even reaches the upper part of the esophagus, it equilibrates with the body temperature. And it's actively evaporated in the nasal turbinates itself by the high flow of dry air. So we don't really, we're not really concerned about the interpretation of the data, because we are collecting multiple data points. As Wendy said, we are collecting data from the spot-on, collecting data from the tympanic temperature probe, and from the esophageal temperature probe, which is often placed pretty deep in the esophagus. So I think that the pattern of cooling in all three probes would suggest a whole body loading of temperature as opposed to a local effect.
In the initial study, in the pilot phase, although both the tympanic temperature and the esophageal temperature decreased, the core temperature, which was esophageal, the absolute decline was actually greater than in the tympanic temperature.
One other question regarding the portability of the new device that you all are piloting. How portable would that device be?
It fits on a IV pole. It can be it's the size of a big lunchbox, and it can be moved anywhere. And because it fits into a wall air port, it can be moved with the patient if the patient's going for a CT scan. But if it goes for a CT scan, it can be moved along with the patient. Just would fit like a cardiac monitor on the side of the bed.
Mm-hmm. Do you foresee it being capable of being deployed in the pre-hospital setting or during prolonged interfacility transports?
This is exactly the reason this technology was designed, to be portable, to be able to be used in a pre-hospital setting. It could be battery operated to last for up to 2 hours of transport. So this is something that can easily be portable. All it has is a fan, a blower with a desiccant cartridge, and some electronics to make sure that there is enough feedback loop and feedback control. So this, by design, is a portable device.
Wonderful. Any other points or comments you want to make about your data or your next phase study?
Well, we're doing a three-site study, and we've already, as I said, enrolled about a dozen patients, and so we're looking for more patients, and hopefully within about a year or so, we'll have more data to report.
Wonderful. Well, we certainly look forward to the results of that. This sounds like a very promising methodology for temperature control in our acute brain injured patients. So wonderful. Thank you for this work, and thank you for the time you've taken to discussing it and answering our questions.
Thank you.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care OnCall is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care OnCall, visit www.neurocriticalcare.org/OnCall. Use promo code PODCAST for an extra 10% off your subscription.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Stern-Nezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.